Let's begin with the case challenge. So a 69-year-old lady, fairly old lady, was brought to casualty as she was found unconscious on the floor with some vomiters. The floor was soiled because of vomiters. She appeared confused and she did not respond to any of the questions. So this is the history. This is the chief complaints. So what do we do next to this patient? What do we do next? Through your chat box, can you reply? Okay, someone is asking for temperature. Temperature is fine. Temperature is fine. She's not febrile. Anything else? Okay, coming to vitals. Vitals in this patient, she was stable. Patient was stable. So in the HOPA, would you like to ask anything else? In the HOPA, we get to know that through HOPA, we get to know that patient was unconscious with some amount of altered mental status is present. Some amount of altered mental status is present through HOPA. In the past history, anything you would like to ask in the past history? Past history is significant in this patient. So the patient is not diabetic, but the patient is hypertensive. Patient is hypertensive. Yes, very good, Sharanya. Medication intake and hypertension. The patient was on hypertensives, but she was not controlled. She was not controlled on the regular hypertensive she was taking, and she was regularly around 180/110 used to be her BP. Following this, the doctors gave her thiazide diuretics. Hydrochlorothiazide was given. And 2 days following this, she developed these symptoms. 2 days following this. There is no previous history of seizures. This is the history from past history. So past history includes treatment with thiazide diuretics from the past 2 days, wherein she went to hospital to check for a routine checkup, and this happened. So nothing significant in her family history was present, and personal history also nothing that significant. So next, coming to examination. Vitals were stable. Vitals were stable in this patient. Vitals were fine. She was doing fine. So since the patient is unconscious, first thing to be checked in this patient is ABC, airway, breathing, and circulation, so that since she's unconscious with some amount of altered mental status, we might have to intubate if the respiration is not fine, or if she's so ABC was fine in this patient. So next, other things we couldn't examine because of her altered mental status. Rest of them cannot be examined properly. So next, coming to investigations, what all you would like to do in such emergency situation? One is RBS to look for hypoglycemia. RBS was normal in this patient. ABG, yes. Serum electrolytes, very good. Serum electrolytes showed sodium levels were around 115. Sodium levels were 115 milliequivalents. So anything significant? What could have been the cause? The patient looks somewhat like encephalopathy because of altered mental status. Encephalopathy we can think of. So on thinking encephalopathy, we can think of first emergency causes after ruling out ABC. Since ABC is fine, we can think of doing one RBS and serum electrolytes, looking for metabolic encephalopathy. And metabolic panel revealed, yes, metabolic panel revealed sodium. Sodium was so low. So it is, the case is nothing but acute hyponatremic encephalopathy. What could have been the cause? Avantika? Yes, very good diagnosis. Drugs, yes, very good. Thiazide diuretics led to hyponatremia. What is the pathogenesis? Why encephalopathy? Anyone? How is it relevant to our discussion today? Okay, all of you answered it. Good. Thiazide diuretics led to old age being the precipitating factor, led to hyponatremia. Hyponatremia understood. How is it relevant to our history today? How will we go into the no. How is it relevant to our history of edema today? Yes, very good. Pooja, cerebral edema. Cerebral edema. Hyponatremia. What has caused hyponatremia means the extracellular becomes hypotonic. Since the extracellular fluid becomes hypotonic, inside the cell it is hypertonic. So the fluid tends to move in, which has led to cerebral edema. Cerebral edema. So broadly, we can categorize edema into So firstly, what is the definition of edema? Edema is nothing but presence of excessive fluid in the body tissues, and this can be broadly categorized into this fluid. There can be intracellular fluid as well as extracellular fluid. So in case of intracellular edema, as we saw in our case, the first case was a case of intracellular edema. You will have what can be the causes, what all can you think of? As we saw, one of our case, hyponatremia, or it can be due to depressed metabolism or lack of adequate nutrition. What happens over here is the cell doesn't have, like when in case of shock or in case of chronic malnutrition, what happens is not enough amount of nutrition is reaching the cell. That will lead to some amount of cell damage. That will lead to edema, or it can be because of inflammation. Again, cell membrane damage, direct cell membrane damage can lead to intracellular edema. So these are the causes we can think of intracellular edema. After intracellular, next comes the extracellular fluid. This extracellular fluid comprises of plasma and interstitium. So plasma comes inside the blood vessel. So that won't be relevant to our topic. What our topic is accumulation of fluid in the interstitium. That is relevant. That causes edema. So one can be because of increased capillary filtration of the fluid from the blood vessel. The capillaries become more filterable, and the blood moves out from the from the blood vessel to the interstitium. That can be one of the cause, or it can be because the fluid that has already moved in, the lymphatics, usually whatever fluid comes into the interstitium, the lymphatics collects those fluid and delivers it back. If there is failure of that lymphatics to perform, then also we can have edema. So failure of lymphatics to return the fluid. This leads to an entity called as lymphedema. So let's see a condition. Let's see a clinical case of lymphedema. A patient who underwent surgery for breast malignancy. Presents with this after 1 year. What is this? No, seroma would have presented much more acutely. No, the first picture is not that. Edema. Edema is because of what, Anuga? Yes, very good. It is a case of lymphedema because, yeah, dissection, lymph node dissection will be done during the breast malignancy, which has precipitated into lymphedema. So the next is the same patient after 5 years presents with this. After 5 to 6 years, she has presented with this. What has happened now? Yes, what is it? Sharanya, what is it? Stewart-Trevis syndrome. Yes, good. Can you explain what this Stewart-Trevis syndrome? Yes, lymphangiosarcoma. Yes, very good. So this was lymphedema, which is complicated to become Stewart-Trevis syndrome. Stewart-Trevis syndrome, which is nothing but lymphangiosarcoma. So how does a patient with lymphedema presents? How does a patient? He'll have various symptoms. Few of them being swelling will be the most prominent symptom. Constant dull ache can be there, even along with severe pain at times. Bruising and burning sensations can be there. Generalized tiredness and debility, sensitivity to heat, pins and needle sensation, cramp, and certain skin problems can be there because of chronic lymph accumulation, or it can be patient can become immobile very soon due to progressive lymphedema and all the other features. So on examination, what is characteristic of lymphedema? It is non-pitting edema, because if there is accumulation of fluid, then we can have pitting edema. Since this is something that leads to accumulation other than fluid, then we can see something called as non-pitting edema. Where else we can see non-pitting edema? Anyone? Where else can we see non-pitting edema? Yes, mixed edema. Anything else? Yes, good. So you people are aware of it. Where all we can see non-pitting edema. So filariasis, lymphedema itself, filariasis causes lymphedema. So what other causes was what I asked. Then lymphedema, what can be the causes? One is primary lymphedema. This is either congenital variety or idiopathic, which presents later on, or it can be due to certain other damages. So what all we'll look for in the history, usually we'll ask for tissue or trauma damage, which has led, wherein it can be because of past history of surgery, past history of radiotherapy, past history of lymph node dissection, as we saw in our case, or burns, which has led to the condition. Then we can think of some amount of malignant disease. Either it's because of lymph node metastasis, then the lymph node will not be able to drain, which will lead to accumulation, or infiltrative carcinoma, lymphoma, all those things. Then comes venous diseases like chronic venous insufficiency, venous ulcers. Then very, very important, infection, especially in our country, filariasis. In South India, filariasis becomes very important. Then there will be chronic infiltration, as in case of cellulitis, can progress to this. Then inflammation also can cause, and these are certain other disorders which can cause lymphedema. So how do we evaluate a patient of lymphedema? We do routine tests, which include CBC, RFT, LFT, serum electrolytes, all the routine panel, along with ultrasound to see what the pathology is, whether it is venous or lymph accumulation. And we can do lymphangiography as well. Still, if it's not diagnostic, we can do a CT or an MRI for this. So this was about approach to lymphedema. Next we shall see. So till now we saw accumulation of something that is not fluid in the interstitium. Next, if we look at fluid infiltration, we'll think of what all can lead to increased accumulation of fluid because of the increased capillary filtration that is governed by what we read in physiology called as Starling forces. That is governed by the Starling forces. So filtration equals, this is the formula, Kf standing for vascular permeability from, so inside the blood vessel, which includes intracapillary hydrostatic pressure minus the interstitial fluid hydrostatic pressure. This was in the interstitium, and this is again oncotic pressure in the capillary, and this is oncotic pressure in the interstitium. So among these forces, this is the filtration. This is the formula for filtration. Among these forces, which of them contributes to increased capillary filtration? That is important for us because that is the one that leads to edema. So which leads to edema? One is increased capillary filtration coefficient. That is nothing but Kf. If this is increased, automatically, if the capillary becomes permeable, automatically fluid moves out. So one can be that. Next, it can be due to increased hydrostatic pressure in the capillary itself. So if there is more amount of fluid, that increases the load. If there is increase in the load, the fluid automatically moves out. Yes, very good, Avantika. And the last one can be because of decreased oncotic pressure in the plasma. If there is decrease in the oncotic pressure, there won't be enough amount of osmolarity will decrease. There won't be enough amount of solutes to hold on to the water. So the fluid inside becomes hypotonic and it will go out of the blood vessel and accumulate in the interstitium. So all these things can lead to edema. So next we will see how do we classify edema. How do we classify edema is based on these factors itself. Like what all causes these factors, whatever pathology causes any of these factors will lead to edema. So this is how we classify, and this is how we approach edema in our history as well. So let's look into the classification. First one is increased capillary pressure, increased capillary hydrostatic pressure. So we are looking into this aspect. We are looking into this one. Increased capillary hydrostatic pressure. There will be more amount of fluid in the blood vessel that will push out the fluid because of the pressure. So one can be due because of volume expansion. Volume expansion. There is more amount of fluid that is getting accumulated in the blood vessels. When does it happen? It can happen in acute or chronic renal failure. When the kidney fails to produce urine, that happens in case of renal failure. Another one will be mineralocorticoid excess or Cushing syndrome. In this, what happens? There will be more amount of aldosterone. If there is more aldosterone, more sodium retention. If there is more sodium retention, water gets reabsorbed from the kidney. So again, there will be more amount of water retention that causes volume expansion. In case of pregnancy, we have increase in the intravascular fluid that causes. Then in case of diet-induced acute salt overload, like a patient consumes large amount of salt or salt-containing food, or it can be because of side effects like NSAIDs or steroids. Steroids, again, because of Cushing's. NSAIDs because they cause arteriolar, I think so, it causes afferent arteriolar vasoconstriction. So that leads to less amount of fluid getting filtered itself. Then it can be because of excessive amount of IV fluids. We are loading the body with fluids, or it can be because of heart failure. The heart compensates by increasing the amount of fluid through the RAS system. That will lead to increased fluid in the body. So this can be because of volume expansion. Next, what else causes increase in capillary hydrostatic pressure? If the heart is not pumping out the blood, then because of the back pressure, fluid gets accumulated in the veins, in our veins, which will lead to high venous pressure and insufficiency. So what can cause? Obviously, it is nothing but heart failure. Heart failure is the main cause, and all these things which will lead to heart failure itself. Valve abnormalities in which leads to heart failure can cause this, or cardiomyopathy and constrictive pericarditis and cardiac tamponade. Then comes SVC syndrome, superior vena cava syndrome. Then it can be because of any abdominal mass and pregnancy compressing onto the IVC or the iliac veins, or it can be because of deep vein thrombosis, wherein a thrombus will not let the blood to come back to the heart, or it can be because of chronic venous stasis. Again, it can be because of any compression or any thrombus, anything, or it can be due to prolonged immobilization. When there is prolonged immobilization, the calf muscles are called as peripheral heart. They are not working, so they are not pumping the blood back into the heart. So that can cause. So the last being decreased arteriolar resistance. Arteries itself have resistance in them, which we've read in our physiology. If there is decreased resistance, fluid moves out. So it can be because of excessive body heat, insufficiency in sympathetic nervous system, or drugs like calcium channel blockers, which dilate the vessels and cause this. So the next one is decreased oncotic pressure. So less solute inside the vascular tissue, inside the blood vessel. If there is less solute, the osmolarity decreases, fluid becomes hypotonic and moves out. So what can be the cause? One is nephrotic syndrome. Because of high amount of proteinuria, proteins are lost in the urine, which will cause hypoalbuminemia, which will lead to this decreased oncotic pressure. Malnutrition, insufficient intake will lead to, again, less amount of protein, or it can be due to malabsorption, or it can be due to cirrhosis of liver, wherein albumin is not being produced itself, or in case of burns and wounds, which is lost. The proteins will be lost, which will lead to decreased oncotic pressure. Next will be what we are left with? We are left with increased KF, increased capillary filtration coefficient, wherein the capillaries itself are damaged or the pores increase in size, which will lead to this. One is, what can be the cause? Sepsis. Sepsis, what happens? The blood vessels are damaged by the toxins or by the inflammatory mediators, which causes increased capillary permeability. Same accounts to cellulitis. And then comes immune reactions or toxins like snake bite, something can cause this. Vitamin C deficiency, again, vitamin C is required for collagen formation, blood vessel formation, which causes this. Burns, again, drugs like ACE inhibitors, because angiotensin converting enzyme, bradykinin, angiotensin converting enzyme degrades the bradykinin, but there will be, when it is inhibited, there will be more amount of bradykinin. This bradykinin causes vasodilatation that increases the capillary permeability. Hypothyroidism, because there will be increase in antidiuretic hormone, and hereditary angioedema. This is again by immune mediated damage. So pathologically, how can we see it? Pathologically, this fluid that is accumulated can be transudative or exudative. Transudative being the protein poor fluids seen in malnutrition, chronic heart failure, or CKD. Exudative being protein rich exudates seen in sepsis and cellulitis. So let's look into next case. In this, a 16-year-old girl came with complaints of weight gain and progressive swelling of both lower limbs. Since progressive swelling of both lower limbs, and this has been occurring since past 6 to 7 months. And she had her puberty onset once she reached 15 years. So what will you ask in history? A patient comes with edema. What do you ask in history? What do we ask in history? Okay, someone is telling urinary output. Urinary output is normal. No menstrual irregularity. Menstrual irregularity, since she's just now started with puberty, yeah, some amount of irregularity is there. If you're thinking of hypothyroidism, well and good, but no, it was not there. Yes, Avantika, very good. This is the basic history which we ask in edema. Whichever patient comes with edema, first we'll have to ask for onset. Next, we'll have to ask for diurnal variation. Then we'll have to ask how it progressed. So this particular girl, onset was from the past 7 to 8 months. It has slowly progressed, but what was characteristic is feet were not inward. Her feet were not inward. Feet were not inward. It was from above ankle. It was from above ankle, and it has progressed to involve thighs as well. Progressed to involve thighs as well. So this was characteristic about this patient. Next, coming to past history, nothing was significant, but family history was significant because even her mother, family history, when we looked into family history, her mother as well has similar complaints, and she also had the onset when she reached puberty. And she had reached puberty. She also had the same thing. So next, yes, Rishabh is going towards lymphedema, but it is a very good differential diagnosis of lymphedema. But over here, in lymphedema, it is mostly asymmetric edema. Over here, it was bilateral and symmetrical. Bilateral and symmetrical edema. Bilateral and symmetrical edema, sparing the feet. Sparing the feet. Sparing the feet. On examination, it was non-pitting. On examination, it was non-pitting. Non-pitting. With this, we should be able to make diagnosis. Anyone? A female patient? No. Skin remained normal. Skin remained normal, Sharanya. No. There were no other symptoms of hypothyroidism. So, no, it was not a sudden onset edema for angioneuritic. Thyroid function tests were normal. No, there was no, it was not, it's not filariasis. Peripheral smear did not reveal anything. Collagen disease, so you're thinking of something in some infiltrative disorder. It is an infiltrative disorder because it is presenting with non-pitting edema, but no, something characteristic is there. That is, it doesn't involve the feet. It is above the feet. All this edema, it starts from the feet. All these edema, it will start from the feet and move above, but this is starting above the ankles and moving above. So the feet are not involved itself. Now, could you think of anything? No, not Edison's. So can I tell the diagnosis? Can I tell the diagnosis? No. AA malformation, again, it would have presented with asymmetric edema. There is no pain for it to be DVT, and it is chronic from past. No, valves of lower limb. Again, this is symmetric edema. No? Yes. Rishabh, very good, Rishabh. You got it right. The diagnosis is something called as lipedema. Fat infiltration. Very good. On doing MRI for this patient, she had subcutaneous fat infiltration. Subcutaneous fat infiltration was present in this patient. So the diagnosis is lipedema. Okay. So yes, very good, Avantika. Avantika and Rishabh got it. So let's move ahead. What were we looking at? We were looking at the classification. Now coming to history. Coming to history. Based on age, how can we divide pediatric? What is common? Congestive cardiac failure, mostly resulting from some congenital heart disease, or can be because of rheumatic fever leading to RHD, or because of some malnutrition leading to congestive heart failure, or anemia leading to congestive heart failure, or congenital valvular abnormalities, again, which will lead to congenital heart failure itself. Malnutrition being very important cause. Which malnutrition causes edema? Marasmus or kwashiorkor causes edema. Then it can be nephrotic syndrome in children. Which is the most common nephrotic syndrome in children? Next question is, yes, kwashiorkor, very good. Most common nephrotic syndrome in children. Next question. Or it can be some congenital lymphedema or hereditary angioedema presenting in the kids. Which nephrotic syndrome is most common in children? Then comes middle age. What can be the cause? Hypothyroidism. Hypothyroidism, again, non-pitting edema. It is mainly because of deposition of hyaluronic acid. Hyperthyroidism also, Graves, it presents with pre-tibial mixed edema because of lymphocytic infiltration and inflammation. Then it can be something like Cushing's, vasculitis, again, nephrotic syndrome, pregnancy. Yes, all of you answered. It is minimal change disease. Very good. In case of adults, which is most common? Adults, which is the most common nephrotic syndrome? Then comes old age. It can be because of immobilization, peripheral pooling, CCF, and renal failure. Yes, very good. FSGS. Malignancy, cellulitis, because patient will be diabetic, he's prone to infection, and chronic venous stasis like varicose veins can occur. Based on occupation, any long durations of sitting can cause peripheral accumulation of blood, or it can long hours of standing, which has led to venous valvular abnormalities. So it has caused chronic venous diseases. Address, again, in India, the Malabar coast is famous for filariasis. So this is how it's important. So coming to clinical history. Clinical history, when it comes to edema, first, as Avantika had mentioned, we have to first look into onset, whether it was chronic, insidious, slow in onset, or whether it is sudden onset. Next, we'll have to look how the edema progressed. Next, we'll have to look whether it is symmetrical or asymmetrical, and we'll look for diurnal variation. If we ask these simple 4 points, we can localize the edema to one of these. As we read in classification, we can localize the edema to one of these classifications. So simple. History taking in edema should be focused and it can be simple. So firstly, it is duration. Based on onset, it can be sudden and acute and insidious. Insidious, we look for different associated features. But if it is sudden in onset, then we will have to rule out alarming symptoms because some things need emergency treatment. So if it is unilateral, most of the times unilateral, or at times even bilateral, pedal edema, if it's associated with pain, we should think of DVT and do an ultrasound. Or if it is because of any new medication or something the patient is allergic to, they know it, like some drugs or some food item, and then or exposure to latex and chemicals, who presents with rashes, dyspnea, nausea, vomiting, dizziness, we can think of anaphylaxis as the cause. Or if we comes with all these features, we can think of heart failure, or most important emergency is cardiac ischemia. Then these symptoms like syncope or pre-syncope symptoms, we can think of outflow tract obstruction, or very important, pulmonary embolism. Then all this history along with altered mental status, fulminant liver failure, which is leading to nothing but hepatic encephalopathy, we'll have to think of. Then if the patient has history of DVT along with some history of fracture, like neck of femur fracture comes with chest pain and dyspnea, we'll have to think of pulmonary embolism, which becomes again very important. Or it can be like post-traumatic, something like fracture or snake bite, which has led to edema. In these cases, very, very important is to look for peripheral pulses. Look for peripheral pulses and see that there is no blood compromise, arterial compromise, okay? Or else we'll have to do something like fasciotomy to that patient. So very, very, very important to look for the peripheral pulses. So next, before going to this, let's look into this question. Let's look into this question. Can you solve this question? Patient comes with edema. Patient comes with edema, and this being the history. What is the most likely diagnosis in this patient? What would be the most likely diagnosis in this patient? So it is patient with edema, bilateral pedal edema, with, he has 10 years history of diabetes mellitus, and he has cholesterol levels are very high. So what can we think of? Yes, excellent. It is nephrotic syndrome. Diabetes mellitus leading to nephrotic syndrome we can think of in this patient. Yes, very good. Very good. And there was nothing suggestive of congestive heart failure in this patient because there's no shortness of breath or on exertion or orthopnea PND. No such history was present. There was no chest pain palpitation as such. For this to be diuretic induced edema, again, there is no history suggestive of it. So hypothyroidism, again, it would have been non-pitting edema, but this is pitting edema. So all we have left with this a diabetic patient with this thing is nephrotic syndrome. Yes, hypertension also contributes. Very good. So next we'll see the distribution and progression. One, in this distribution, it can either be a symmetric distribution or asymmetric. First, symmetric means we look into heart failure. Heart failure as one of the cause. In case of heart failure, what is classical? If the patient is ambulatory, we'll see something called as dependent edema. Because of the back pressure, there'll be dependent edema. Edema in the legs, more towards end of the evening, because the patient will be working the heart from morning till evening. It will be trying to compensate. By evening, the heart will become decomposed. Slowly will move towards decompensation. That will cause this pedal edema more towards evening. If the patient is recumbent, again, since it is dependent edema, it will be usually in the presacral region. If it is severe, it again progresses upwards. It progresses slowly upwards. Legs will get involved, followed by face, followed by the ascites. So this is how it progresses in case of heart failure. If it is because of cirrhosis, first the patient will have ascites. Ascites comes first. This ascites is followed by legs. This is followed by face. This is how the progression in case of cirrhosis. If hypoproteinemia is the cause, as in nephrotic syndrome, if it is because of nephrotic syndrome, then it usually involves the soft tissue. It starts initially in the soft tissue, because since soft tissue, more amount of fluid can go and accumulate. It is easier for the fluid to accumulate. So first it accumulates in the periorbital puffiness or in the facial puffiness, which will further become generalized and form anasarca. So, and this is most pronounced in early mornings. Again, because the patient will be in recumbent position, because of gravity, since the patient is in recumbent position, and because of gravity along with loose tissues in the eyelids, there it comes first, most prominently in the morning. Facial edema can be seen in case of allergic reactions, mixed edema and all, facial edema comes. So main differential diagnosis is heart failure coming with dependent edema, nephrotic syndrome patients coming with periorbital puffiness and facial edema, renal failure as well presenting with similar complaints. And if it is a malnutrition patient with hypoproteinemia, then they as well again come with pedal edema progressing upwards. Okay. Next, we'll look into causes of asymmetric edema. Asymmetric edema, it can be unilateral edema. It can be because of venous disorders like valvular abnormalities, which will lead to varicose veins, or it can be DVT, or it can be thrombophlebitis, or it can be because of venous compression by some tumor, or it can be because of pregnancy, or it can be because of venous occlusion by a thrombus, etc. If it is superior vena cava syndrome, again, what is characteristic about this is edema is confined to the upper extremity, usually to the face, neck, and upper extremities, okay, as compared to lower limbs. That is why it is superior vena cava syndrome. So more confined to the upper part of the body. Then lymphedema can be unilateral. It can involve only one limb, or it can be inflammatory edema as well, will be unilateral edema. Then where else fluid can accumulate? Fluid can accumulate in potential spaces in the body, like ascites, pleural effusion, pericardial effusion, and all. These two things we'll again deal it in some other class as to approach for pleural effusion and ascites. This as well as is important. We'll deal it in some other class. So next we'll look for associated features. What are the other associated features? So our aim, as we saw in the starting, is to classify into the 4 main categories depending on the stalling forces. So first was increased hydrostatic pressure, which can be due to volume overload. So if it is volume overload, what are the other associated features or history you will ask for? If the patient is on IV fluids, which has led to volume overload. If the patient work outdoors and in hot climate, then there can be something called as steroid-induced edema. Steroid-induced edema. What happens over here is, since patient is continuously working under hot climates, patient will be dehydrated. That will lead to increased aldosterone synthesis, which will lead to fluid accumulation. This accumulated fluid presents as edema by the end of the day. That is nothing but steroid-induced edema. Then it can be, if the patient has something like weakness, weight gain, or skin stretch marks, we can think of Cushing syndrome. Along with hypertension, we can think of mineralocorticoid increase, like something like Conn syndrome. Or if there is history of decrease in urine output, along with uremic signs and symptoms, we can think of renal failure. Both these things, what is important is increase in BP. Patient will be hypertensive. And these being the features of uremic signs and symptoms. These being the features of uremic signs and symptoms. Then comes high venous pressure. Next cause for increased capillary hydrostatic pressure will be high venous pressure. Most prominently, it will be heart failure. Usually, under most of the circumstances, cause for high venous pressure is when there is symmetric edema, then causes heart failure. So what we'll ask for? Dyspnea, exertional dyspnea initially, which progresses further along with orthopnea and PND, or dyspnea along with exertion, and then we look for if there was MI, if the patient has consumed alcohol, or peripartum cardiomyopathy, or if there are any infiltrative disorders, then we can think of cardiomyopathy to be the cause. Or we can look for any valvular abnormalities which has led to heart failure. So these are the history. If there is CAS, patient will be hypertensive, old age, presenting with dyspnea, loss of consciousness, sudden syncopal attacks, chest pain, etc. If the patient is having dyspnea, is having history of IV drug abuse, then we can think of infective endocarditis affecting the aortic root, causing aortic regurgitation. If he is again IV drug abuse or an RHD patient, we can think of MSMR or other valves being involved, like pulmonary, tricuspid, all those valves as well can get involved. If the patient has history of tuberculosis or any lung malignancy, we can think of constrictive pericarditis. And tuberculosis can cause cardiac tamponade as well. Differential diagnosis for constrictive pericarditis and cardiac tamponade, very important as to how do we differentiate these two. Please read this up. Since we don't have time for today's session, we'll discuss it sometime later. Abdominal mass, this won't be symmetric edema. Because of abdominal mass, pregnancy, that will lead to limb edema. Or if the patient is immobile for a long time because of some other comorbidities, if he's immobile, or he's been having past history of clots, OCP intake, or his female presenting with previous history of miscarriage, APLA, if we are thinking of, we can think of deep vein thrombosis as the cause. Or if there are prominent leg veins, again, varicose veins. Varicose veins can be the cause for high venous pressure. If it is because of decreased oncotic pressure, what all we'll ask in history? History of diarrhea, suggesting of malabsorption. If it is because of liver cirrhosis, we'll ask disease symptoms specific for liver disease, which we discussed extensively in our previous class. Or if it is because of nephrotic syndrome, he'll be patient with chronic diabetes mellitus or hypertensive patient, or he's been having history of any other kidney disease presenting with foamy urine because of high amount of proteins, we'll think of nephrotic syndrome. Next, because of increased capillary permeability. What all we can think of? One is anaphylaxis. If it is because of anaphylaxis, what will be the history? Consumption of any allergic food which the patient knows that is allergic to, or any medication presenting with dizziness, rashes, or dyspnea. Hypothyroidism patient will ask for symptom of constipation, cold intolerance, he feels tired, dry skin, coarse hair, all these things become important. If it is hereditary angioedema, it will be episodic in nature. Episodic in nature, prominently involving the lips and face. along with if it progresses to involve and cause laryngeal edema, it causes difficulty in breathing as well. If there is any fever along with some foci of infection, we can think of sepsis. And if there is localized edema, redness, pain, and increase in temperature, we can think of cellulitis as the cause. Then very, very important for edema is drug history, because many drugs can cause. NSAIDs, as explained before, the mechanism, it can cause antihypertensive drug. The various like calcium channel blockers can cause vasodilatation and cause this. ACE inhibitors, one is because of bradykinin, it can cause, or it can cause all those. Because of bradykinin induced, it can cause. So direct vasodilators, arterial vasodilators, because of dilatation, there will be more hydrostatic pressure, and that can cause. Calcium channel blockers as well cause. One is because of vasodilatation, another one is because of accumulation of fluid. CC calcium channel blockers can cause. Then steroid induced because of aldosterone. So there are many drugs. Please do ask for drug history. Then if it is premenstrual, if the edema is usually premenstrual coming monthly, we can think of something called as cyclical edema. If there are surgical history, as we saw, lymphedema, as we had discussed on, lymphedema can be a cause. Then what is very important is history of weight gain is important in edema. This is not only, one is for progression of the disease, other one is for treatment as well. For one is to look for how far the disease has progressed, another one is whether the patient is responding for treatment or not. One, we can see it through the eyes, the edema disappearing. One more is there will be weight loss in that patient if he is responding to the treatment. So history of what is the amount of weight gain and how the patient progresses further is very important for us. Then in personal history, diet, food rich in salt or excessive salt intake itself can cause edema. Sleep, if it is altered, we can think of something like uremic or hepatic encephalopathy. If appetite is decreased along with metallic taste, we can think of chronic renal failure. In malnutrition, if it is marasmus won't present with edema, just to differentiate marasmus from kwashiorkor. In marasmus, appetite will be good or it will be increased. In kwashiorkor, poor appetite will be there. Urine output you ask for because it will be decreased in case of renal failure. Alcohol and smoking as well can contribute. And bowel habits, constipation is there, we can think of hypothyroidism. So let's look at few interesting cases now. So case number 5. Over here, what happens is a 28-year-old lady, she presented with left leg swelling for almost 3 years. Okay, so from history, what is evident? From history, what all we should ask for? How the onset was. It was insidious in onset in this case, and how it has progressed. And distribution, it is asymmetrical edema because it just involves left leg, and it has been slowly progressing since from the past 3 years. How it progressed? It's been progressing from the thighs. If initially it involved the thighs, then it went on to involve the full lower limb as well. From thighs, it went on to progress and involve full lower limb. So this was the history. And on examination, we'll see whether it is pitting or non-pitting edema. It was pitting edema was present on history. So from history, we can make out that it is an asymmetric edema, which is pitting in nature. So there is some amount of fluid accumulation. So we can think of some amount of venous disorder in this patient. So bilateral venous ultrasound Doppler was normal. CT scan revealed something, and for that particular thing, patient was treated, and post-surgical, this was the MRI finding. This was the CT finding, not the MRI finding. This was the CT finding in the patient. Look, over here, they've done certain procedure over here. Can anyone diagnose with this history? Can anyone diagnose what it is? And what was the CT scan finding in this patient? Okay, Sharanya, very good. Iliac stent, occlusion. Why occlusion in this patient? What was the cause for occlusion? Mass, no. There was no mass reveal. Yes, Hariharan, very good. It is May-Turner syndrome. It is May-Turner syndrome because on CT scan, it was found that there was the left common iliac vein, as we see over here. This is the left common iliac vein that they have put a stent. The left common iliac vein was being compressed by the right common iliac artery. So this was the case which led to the asymmetric limb edema. So let's look into the next case. 22-year-old weightlifter. Weightlifter is important. Noticed sudden onset painful swelling of his left upper limb after his routine exercise. After his routine practice of weightlifting, he noticed this. Okay, so from history, what was evident is, from history again, it was evident that it was asymmetric edema involving the upper limb. Asymmetric edema involving the upper limb, which was sudden in onset, which was painful, Subclavian steal syndrome, you'll have some other symptoms as well. Here, there is nothing else present. There's just unilateral limb edema along with yes, because on doing, yes, very good. You guys got the diagnosis right, because on doing further venous ultrasound, a thrombus was found in left axillary vein. A thrombus, since it was acute in onset and painful, thinking some amount of obstruction might be there, they did an ultrasound. They found a thrombus. Again, on doing X-ray, they found cervical rip was present in this patient, and this was post-stress induced. So post-stress induced accident. See over here, there is occlusion along with some amount of neovascularization as well. Occlusion. We can diagnose this patient to be Paget Scrotter disease. So this is nothing but a variant of deep vein thrombosis only. So upper limb deep vein thrombosis. This is a variant of deep vein thrombosis only. So very good, you guys diagnosed it right. So let's see whether you can diagnose this condition. Next case, a 15-year-old kid presents to OPD with progressive bilateral pedal edema since the past 15 days. This being the chief complaints. So next we'll go to HOPI. What do we ask? In HOPI? Since we know how to ask for history in the case of edema, what do we ask? Past upper respiratory tract infection? No, it was not there, Anaga. There was no history of urinary complaints. There were no urinary complaints as such. Facial puffiness? No, Avantika, it was not there. Progression one, it was insidious onset involved the initially started from the foot and ankle. Now it has progressed till knee. So bilateral pedal edema, pitting and symmetrical. Pitting in nature, and it is symmetrical. So this we can think from history. So no, there was no. Yes, 1+. Very good. You asked for history of dysentery. There was history of diarrhea. Diarrhea is present from past 15 days. Along with some amount of steatorrhea also. So foul smelling stools, large volume foul smelling stool also is present. So Pallavi is telling malabsorption. Yes, Hariharan, very good. Protein losing enteropathy. You've got it. Why protein losing enteropathy? Why? So, okay, you guys are thinking protein losing enteropathy and malabsorption to be the diagnosis. Okay, hemolytic uremic syndrome as well, we can keep. Okay. So these are your differential diagnosis. So in the past history, I'll tell you something significant. The patient was diagnosed with celiac disease and was advised to avoid gluten, but he did not follow this. And presented with these symptoms. Yeah, Anaga, celiac disease, and was present. So now, among this, we can rule out HUS. It can be a case of primary malabsorption itself or protein losing enteropathy. IgA nephropathy, there was no history of infection. There was no history of past infection. So upper respiratory tract infection was not there. So this was the something significant in the past history. So next, how can you confirm one among this to be diagnosis? So this is the differential diagnosis. You came at the end of examination and history. Okay, very good. To tell it is protein losing and antibody and biopsy, yeah, that will prove that it is celiac disease. But what is causing the edema in this patient? Anyone? Few of you told it is protein losing enteropathy. What will you like to do for protein losing enteropathy? How will you confirm? This? Yes, Anaga, we do that too. Okay, serum albumin level were decreased. Endoscopy along with biopsy showed the villus atrophy. Was present. Albumin, since they asked for protein levels, albumin and globulins both were decreased. If only albumin is decreased along with globulin being normal, we'll have to think of something else. Since albumin and globulins both are decreased, we are thinking of protein losing enteropathy. Anything else which is diagnostic, we do something called as alpha-1 antitrypsin level in the stools. So this will be increased because protein losing enteropathy. So what happens over here is, and since it is not any other malabsorption syndrome over here, because celiac disease itself could have contributed to edema, but it is protein losing enteropathy. Why? Because if there was malabsorption, then there could have been other deficiencies as well. Other symptoms of other vitamin deficiencies as well would have been present. This is pure protein losing enteropathy because there is villus atrophy. No, once there is villus atrophy, the GI epithelium is damaged. That will cause high amount of protein to exit through the GI epithelium, which is measured in terms of alpha-1 antitrypsin deficiency, and other absorption of all the other things will be absolutely normal. So there won't be any other symptoms. So this we confirm to be protein losing enteropathy. Okay. So, okay, let's move forward. On examination. What do we look for in examination of the patient in the case of edema? One is general assessment. Altered mental status can suggest hepatic or uremic encephalopathy. And if the patient is emaciated, obviously we can think of malnutrition or any other malignancy. If the patient is lethargic, we can think of kwashiorkor and hypothyroidism. Kwashiorkor can have any other psychiatric symptoms as well. So vitals, pulse rate will be increased in case of hypothyroidism. Graves' disease contributing to pretibial mixed edema. If it is decreased, we can think of hypothyroidism or heart failure. If the pulse is hypokinetic, again, low cardiac output state contributing to heart failure itself. Pulses, paradoxes, if present, again, it can be, we can think of cardiac tamponade or constrictive pericarditis. BP is increased in case of nephrotic syndrome or chronic renal failure. AKI, Cushing's, mineralocorticoid, if you are thinking of this, then it will be decreased in case of heart failure. So temperature, localized rise in temperature can be because of any local inflammation like cellulitis. If we are thinking of central, if there is sepsis is the cause, temperature can be increased. If the extremities only are cool, then we can think of heart failure because heart is not able to pump enough blood till the extremities. JVP is raised again in case of heart failure. If JVP is not raised, still we are thinking that heart failure might be present, then please go ahead and check for hepatojugular reflex. So in head-to-toe examination, if pallor is present, anemia leading to congestive cardiac failure, we can think of, or hypothyroidism. ICTRES, we discussed this extensively in our last class. Cirrhosis and liver disease, we can think of. If cyanosis is present in the pediatric age group, it is usually because of congenital heart disease, which is progressing to congestive cardiac failure. In adults, we can think of respiratory failure or again congestive cardiac failure. Lymphadenopathy, if present, we can think of any abdominal or pelvic tumor compressing the iliac vein and causing the edema. And now coming to parallel icterus, cyanosis, lymphadenopathy, and edema itself. Edema, where all we assess sites, we usually over a bony background, we compress for around 30 seconds. We compress for around 30 seconds. Okay. Usually, if it is lower limb, we see over medial malleolus. If it is over sacrum, just press your thumb and check for edema. If we are suspecting ascites, we press the step over the anterior abdominal wall. Then puffiness of face and lower eyelid can be examined. Anasarca, patient will be edematous lower limb along with ascites, along with upper extremity edema. Sternum also will be there. This as well we can see by putting the stet, or forehead also can get inward. So this is nothing but generalized edema. And scrotal edema. Scrotal edema is again important. If the patient is nephrotic syndrome patient, can have scrotal edema as well. Then next important step in edema is to see after compressing, we see whether it is pitting or non-pitting. If on pressing, it doesn't pit, we'll think of non-pitting edema. As we discussed, the causes of non-pitting edema can be lymphedema, mixed edema, Graves' disease like pre-tibial mixed edema, or systemic sclerosis we can think of. Pitting edema, as we have extensively discussed till now, various causes can be present. Again, look for signs of nutritional deficiency in head-to-toe examination, because malnutrition is one of the important cause for edema. So alopecia can be there, glossitis and stomatitis can be there. Again, marasmus doesn't present with edema. Just to differentiate it from kwashiorkor, we have put like old man or monkey child appearance or baggy pant appearance can be there. And crazy pavement dermatosis, in case if we are suspecting kwashiorkor, there will be crazy pavement dermatosis, flax sign, flaky paint dermatosis, all these things can be present. Then scrotal edema in case of nephrotic syndrome, and look for signs for liver cell failure if a patient presents with ascites and we are suspecting cirrhosis. Okay, coming to systemic examination, first is CVS. CVS usually will get inward in case of heart failure, and what all we can find, if there is cardiomegaly, there can be, because the heart is trying to compensate so that the patient doesn't go into decompensation, there will be some amount of cardiomegaly. In that case, apical impulse will be shifted. Ventricular gallop, S3 can be heard because of volume overload. Parasternal heel will be present again because of hypertrophy. The heart is trying to compensate, so there will be some amount of hypertrophy that will lead to parasternal heel. Sustained apical impulse as well can be because of hypertrophy. And in case of advanced heart failure, we can find regurgitant murmurs like mitral and tricuspid regurgitant murmurs. Because of back pressure, we can find this as well. If we are thinking of any valvular abnormalities, again there will be murmurs will be present. Those murmurs are diagnostic. Then if the pericardial rub is present, it can be because of uremia. We can suspect uremia in the case of renal failure presenting with pericardial rub. RS, look for basal crepes, will be present in case of heart failure, and right-sided pleural effusion will be present in case of ascites. And patient can have dyspnea as well. If ascites is tense, we can have dyspnea as well. That is one of the indication, that is in fact only indication for us to tap therapeutic indication. If abdomen is inward, again distended, like generalized distension with dull note on percussion, ascites will think of. Liver will be shrunken in case of cirrhosis. If it is tender hepatomegaly, tender is very, very important, congestive cardiac failure, or it can be just fatty liver as in case of malnutrition, which has led to hepatomegaly. CNS, we can think of encephalopathy, which is the two things, renal failure, which is leading to encephalopathy, uremic, or cirrhosis or liver failure that is leading to hepatic encephalopathy and its features. So, So next case, this brings us to end of examination. So we look at the next case. Over here, a 45-year-old gentleman comes with complaints of progressive shortness of breath. That means he means to say initially he could walk some amount of distance. Now the dyspnea has progressed. Even at rest, he is having shortness of breath and fatigue since 3 months. So this was his chief complaints. What would you like to ask in case in history? What will you like to ask for this patient? How do we localize it? We should ask in terms of onset, distribution. Cough, chest pain and palpitation. Occasional chest pain and palpitations was present. Occasional and associated features. Associated features. Associated features included palpitation, occasional chest pain was present. So you're thinking of cardiovascular system, cardiovascular involvement you're thinking of. PND was not there, orthopnea was there in this patient. Orthopnea was present in this patient. Orthopnea was present in this patient. So onset, again insidious onset. Insidious in onset it was edema. Initially it started from ankles, now it involves full leg. Now full leg is inward. Full leg is inward. This is so symmetrical edema. Symmetrical edema, bilateral lower limbs. Syncope was not present. Syncope was not present. This is what we think. Yes, on examination it was pitting. On examination it was pitting. On examination it was pitting. Again, on examination, vitals, when we think of, when we check for JVP, JVP was raised in this patient. JVP was raised. Anything else you'll ask for in the history? Auscultation findings. On auscultation, S3 was there. S3 was there. S3 was there. On auscultation of RS, basal Krebs was there. Basal Krebs was there. Is he a smoker? He is not a smoker. So that comes to personal history. Personal history is non-smoker. As of now, no murmurs were heard, Sharanya. As of now, no murmurs were heard. Okay. Congestive cardiac failure, you guys are thinking of. But congestive cardiac failure is a very huge term. This can be divided into, again, high ejection fraction, low ejection fraction, all those things. So next what? BP. BP was 100/60. So he was not hypertensive. No history of previous infection. No. There was no history of previous infection. So what will be your differential diagnosis? Differential diagnosis, you've thought of congestive cardiac failure. What could be the cause of congestive cardiac failure? Okay, his old age, someone of you asked, if I would have told that patient is hypertensive as well, you could have think of aortic stenosis as one of the cause. Dilated cardiomyopathy. Okay, dilated cardiomyopathy is a very good differential diagnosis because you people did not ask for alcohol history in this thing. Patient is a chronic alcoholic. Patient is a chronic alcoholic. Patient is a chronic alcoholic. Next differential diagnosis is dilated cardiomyopathy. So this, how come will be sudden onset, no, Shruti? Sudden onset of chest pain he might come with. Or after some exercise induced something, he can come with. And there is no family history as well. Okay, it has gone into pulmonary edema. We can tell that congestive cardiac failure, which is gone into pulmonary edema. Okay, so what is the cause of congestive cardiac failure in this patient? No, etiology. Chest pain was there. Occasional chest pain he was having. Alcohol is very important in this case. Alcohol is very important in this case. Okay, liver failure, you guys are thinking of. No, there was on abdominal examination, tender hepatomegaly was there. Okay, abdominal examination, tender hepatomegaly. Tender hepatomegaly was there. You guys are missing out something. He is a chronic alcoholic. He is a chronic alcoholic. Alcoholic liver disease, no. Alcoholic myopathy, no. Something much more simpler you can think of. No. His liver, he has some ongoing ultrasound, some amount of fatty liver was present. That's all. Okay. Some amount of fatty liver was present. So this rules out alcoholic liver disease. Okay. Yes. Very good. Very good. Very good. Here, after vitals, pallor was present. One of you asked for pallor. Pallor was present. Pallor was present. Yes. So pallor was present. So next differential diagnosis will be wet beriberi. So suspecting thiamine deficiency, they did thiamine levels, and thiamine levels were found to be low in this patient. Thiamine levels were found to be low in this patient. So it was diagnosed to be wet beriberi. So very good. You guys came to a diagnosis of wet beriberi. So let's move ahead. So we'll see how to approach the case. How to approach a case of edema. Now we've seen the history and examination, like as in anemia or icterus, we don't have any specific investigation as such because it is washed. In edema is washed. It can each system involvement has its own set of investigation. So we can't be particular with investigation, but through our history and examination, we can localize the edema and we can approach the edema. So a simple approach is, first we'll see whether the edema was sudden in onset. If the edema is sudden in onset, if it is unilateral or bilateral. If it is unilateral, please consider DVT as the possible cause. So suspecting DVT, then we'll assess the likelihood of DVT. What is the scoring that is used to assess the likelihood of DVT? It was asked in this year's NEET as well. Yeah, modified Wells criteria. So please be familiar with it. Is very difficult to remember, but I have no idea why the national board asked about this. So please have a look into the criteria. So assess the likelihood. So if the likelihood is low, then we do something called a screening test for DVT, that is D-dimer. If the D-dimer levels are normal, then we'll rule out DVT. If still the clinical suspicion is high, then we can do image testing. If it is high, then we'll do directly image testing. Okay. And if D-dimer levels are high, also we do clinical testing, imaging testing, or through modified Wells criteria, if there is high risk, then it can be image based again. So for imaging, what is this test done? Duplex scan can be done. Duplex scan is best. Duplex scan is the best. Next, if this DVT itself can progress, if the patient complains of chest pain and breathlessness, we can think of pulmonary embolism as well. So if it is not unilateral, if it is bilateral, or if it is either it is bilateral or if it is symmetric edema, then we can think of acute onset anaphylaxis as we discussed. And if it is episodic, if there are certain previous such episodes present involving the face and lips, angioneuritic edema we can think of and measure C4 levels. If it is still DVT itself can present with bilateral or IVC clot also is possible. So do an imaging, ultrasound imaging, and it can be because of acute salt overload as well. So next, if it is chronic, so this was the approach I found in one of the textbooks. So before we look into this, we'll look at this. If it is chronic, this is much more simpler. Acute, we thought of all these conditions. If it is acute, we thought of all these conditions. On examination, we'll see whether it is pitting or non-pitting. This is for symmetric edema, if it is pitting or non-pitting. If it is non-pitting, it can be lymphedema or hypothyroidism will be the most common cause. So directly go ahead and do a thyroid function test. Do a TFT if you're considering hypothyroidism from the history. And lymphedema, we saw how to approach lymphedema in the starting itself. If it is chronic, we go towards history. And from history, we should classify into 4 categories as we saw. If it is due to volume expansion, first thing we'll think of is renal failure. Renal failure, we'll see how the edema is formed and how it is progressed. Early morning, periorbital or facial puffiness is initially noticed and then progressed to in all the rest of the body. We can think of renal failure and work up for it by doing RFT, urine routine, ultrasound, urine output, assessing urine output, doing 24-hour urinary protein, all those things, and differentiate from acute and chronic renal injury. Then if it is not this, then we can think of something like mineralocorticoid excess or Cushing syndrome. Yeah, spot testing also can be done. Then we can think of his medical history, drug history, please ask for, or it can be because of IV fluids. These three can be made out from history. Next, if you are thinking of high venous pressure, most probably symmetrical edema with high venous pressure, we should think of heart failure. So again, history will be shortness of breath, on exertion, orthopnea, PND will be there, along with dependent edema, which is maximum by evening. And then you do workup for heart failure. Heart failure, calculate the ejection fraction that we can divide it into high ejection fraction, low ejection fraction, and do further workup for it. Then we can think of decreased plasma oncotic pressure. In this, what we like to think of is two causes. One is nephrotic syndrome. Nephrotic syndrome, again, how the edema presents is classical, periorbital or facial puffiness, which will further progress and become generalized edema. How do we work up? Measure proteinuria, 24-hour protein you do a lipid profile, look for microscopic hematuria, all these things. If still it is not diagnosed, then we can do a renal biopsy and confirm the cause for nephrotic syndrome and treat with steroids. If it is cirrhosis, then ascites will be there, and approach to ascites we'll discuss in some other session. If it is because of malnutrition, patient presents usually with, again, bipedal edema, and malnutrition, he will have signs and symptoms of other deficiencies. Other deficiencies will be there. Okay, and the last being the increased capillary permeability. Over here, if fever is there, think of sepsis. If it can be because of any immune reactions, again, history will provide it, or it can be because of toxins like snake bite. So next is asymmetric edema. Next is asymmetric edema. It can be because of SVC syndrome. SVC syndrome, we know it can be unilateral. Sorry, not unilateral. It usually involves upper limb, head, and neck more than other parts of the body. Cellulitis, there will be signs of inflammation, or it can be because of venous disorder. And this can be the cause. This also becomes evident with history and how we'll further progress with each investigation. So the basic approach is look whether it is pitting or non-pitting. In case of symmetrical edema, acute in onset, rule out DVT and other causes, anaphylaxis and all, because that requires prompt treatment. Then rule out renal failure, heart failure, nephrotic syndrome, malabsorption, these being the four main causes. And if it is asymmetric, again, do take a very good history and it will become evident. Okay, so I think so. Okay, since we have time, okay, fine. One last case. What can I give? Okay, fine. A kid, he was diagnosed to have kwashiorkor. Okay, he was diagnosed to have kwashiorkor. He was started on oral feeds. But even after starting on oral feeds, after 3 days, they noticed that the edema was progressing. The edema should have resolved. Instead of edema being resolved, the edema was progressing. The edema was progressing in nature. It was still progressive. What can you think of in this kid? What can you think of diagnosis in this kid? Okay, severe. Okay, the kid was a SAM kid. Okay, fine. They diagnosed it to be a SAM kid and they treated with oral feeds. On treating with oral feeds, they saw that the edema was progressing. No, there was no diarrhea and all. This is actually simple, not that complicated also. Right after starting on oral feeds, right after putting him in, giving him a high calorie load, he starts developing edema. Yes, Sharanya, very good. It is refeeding syndrome. Why refeeding syndrome? What is the pathogenesis? Very good. Sharanya, can you tell why? Why refeeding syndrome? What happens over here? Okay, insulin increases. Increase in insulin. What happens? Next. Yes, insulin increase. That will lead to shift in fluid. So what are the classical electrolyte abnormalities in refeeding syndrome? One is hypophosphatemia. Hypophosphatemia is classical. Other than that, you can have hypokalemia. You can have. Other than that, you can have hypokalemia. Other than that, what else? Hypomagnesemia can be there. Yeah, hypomagnesemia can be there. So these are classical, along with progressive edema. So this is it on edema. Any doubts? Hope everything is covered. If you guys would like to add on to something, please tell. We'll add on in the notes, or any other doubts. Fast and slow edema. This fast and slow edema, other than Alagappan, nowhere else it is given. So none of the standard textbooks mention anything about fast and slow edema. That's why I intentionally did not go further and mention Pallavi. Yeah, the notes will be shared in the group. Steroid-induced edema. Steroid-induced edema, what happens is, like, people who work outside in hot climate, what happens is there will be dehydration. Because of dehydration, what happens? The body tries to conserve water. When the body tries to conserve water, there will be more of aldosterone secreted. RAS will get activated, aldosterone will get secreted. That will lead to fluid accumulation. This accumulated fluid, by the end of the day, it comes out as increased hydrostatic pressure, causing steroid-induced edema. Which books did you refer? Many books I referred actually. Kundu was there, Alagappan was there, Harrison was there, Davidson was there. So from many books it's taken from, not just one book. Cause of edema in beriberi. Heart failure, no? Heart failure. Thiamine deficiency has led to heart failure. Yes, high cardiac output failure. In case of beriberi, when there is thiamine is absent, the body's metabolism won't be there. When body's metabolism won't take place, because it is a coenzyme for many enzymes, there won't be enough energy available in the periphery. When enough energy is not available in the periphery, what the heart tries to do? Heart tries to pump more blood. When the heart tries to pump more blood, there will be high cardiac output failure. Initially, the heart compensates, but later on decompensates. Hope you understood, Aditya. Yeah, welcome. Please do attend next session. People interested in research, it will be an interesting session, interactive session by Dr. Ravi Kishore sir. He will guide you regarding your research projects if anyone is interested in it. So I think that's all with the doubt.